wanted to be a doctor most of my life as a kid. My parents immigrated to the US when I was 5. So I grew up in Los Angeles, and I've moved all over the country. And so part of the time was in Canada, Ohio, like we've just been all over the place. And so, had a little bit, many changes and things in my childhood, but that goal of being a physician never really changed. And so, I tried my best to kind of put everything I had into, my college applications and then into medical school. And, it's been a very, I'm very thankful that I'm finally here where I've wanted to be, for the last, like 30 years. And so, it's interesting to just look back at my journey, but I went to Vanderbilt for undergrad and also for medical school. And when I applied, I actually got into medical school as a sophomore. So there was a combined medical program for Vanderbilt that I applied to, and I was lucky enough to get into. And so, I spent 8 years at Vanderbilt, and, a lot of my time as an undergrad, I was part of a community service scholarship at Vanderbilt called the Ingram Scholarship Program. And so it actually gave me a lot of opportunity to, really see the community, do a lot of, public service. And I really wanted to kind of commit myself to a life where not only was I benefiting society, but felt like I was actually doing the public, the service, not saying this correctly, but I wanted to make sure that I was kind of making an impact on, social change and impacting society. And so that sort of, I always wanted, like I said, I was pre-med, of course, in college, but I did a lot of work with health disparities, and that actually got me into research in diabetes. And so I started working on health literacy research in undergrad, and also did my senior thesis on health disparities in the population in Nashville, where Vanderbilt's located. And so, that sort of, I transitioned into medical school, and luckily I was able to continue that research into medical school, and that sort of just continued to grow. And I honestly, I didn't know that I was going to be an endocrinologist back then, but it's really funny to kind of look back and see sort of how the stars align a little bit. I've been doing diabetes research now since I was an undergrad, and I'm still very much entrenched in diabetes management. And so it is kind of funny to see how things go full circle. But in medical school, I gotta say, medical school, no one could pay me to do med school again. It was a hard 4 years. I studied my tail off. I actually failed my first anatomy test. But you know what? It's very much, and this is from somebody who's never failed anything in life. And so it's very much a humble pie, I guess they call it. And so it's interesting to sort of go through, like, and a lot of you are potentially pre-med, and you're smart, and you're used to like doing well. And I think humility in medicine is actually one of the most important things I can emphasize. It's just something that you have to keep in check at all times. And so, everybody at some point or another, whether it was that first anatomy test or, our first surgery rotation where, what we call, we were pimped and didn't get the answer right or something. So everybody, had their moments throughout medical school where humility was served. And so that's something that I highly recommend. Like, if you're going to go into medicine, please retain that humility and retain even some of that idealism, because it really makes for a doctor that really enjoys what they do. And so, I applied into internal medicine residency. I matched at University of Chicago, and started there in 2011. And so ended up doing internal medicine. And, I actually had a really hard time picking my specialty at that time. And so, through internal medicine, we see lots of specialties. And so that would include, of course, endocrinology, but also pulmonary critical care, cardiology, gastroenterology, hem-onc, rheumatology, nephrology. So the sky's the limit, right? So internal medicine is just the base, or you can stay in primary care or do, become a hospitalist, for example. And so I felt like there were too many choices. And so I actually almost did pulmonary critical care. And the reason why is that I actually really enjoyed procedures, putting in central lines, arterial lines, the rapidity and the acuity that we would see. And it was truly it was a rush, right? And I think I thought pulmonology was fantastic. It was very, very interesting. I think still it is really interesting. But then I happened to do an endocrine rotation in my second year of residency. And it kind of, my old research and, like what I did previously, my work in diabetes kind of came back to me a bit. And I really actually started enjoying the physiology, because I think diabetes care and just endocrinology in general has actually really tricky physiology. And so if you understand how hormone pathways work, it's really interesting how it kind of explains like what a lot of things the body does. And so that part, I kind of really enjoyed it. I loved the continuity of care. Loved what a big social impact diabetes and weight management or just obesity was at that time, and it still is. And so that's how I kind of made that decision to pursue endocrinology. And I think the continuity of care is actually what sort of kept me that interested, because I actually love seeing patients, every few months. And now, it's been a few years with certain patients, and I love tracking their progress. I love kind of being their cheerleader. You really form that bond with patients over time where they trust you. You start getting to know their families. I have multiple family members coming to me now. And so I really like that part of my job. And everybody in endocrinology, some people do general endocrinology, some people have a niche. I do a combination of general endocrinology, but my clinical interests include diabetes management, weight management, and I'm actually getting a licensure in culinary medicine. And so I guess if I could, I would do those three things every day, all day, but I do see a range of, general endocrine, and that would include, of course, the diabetes and weight management, but then also pituitary disorders, thyroid disorders, reproductive disorders like PCOS, and like low testosterone, for example. There's adrenal disorders, even osteoporosis. And so, there's lots of different things that endocrine does. And so basically we take care of all the glands, and we work a lot with other specialties. Like, for example, we work with neurosurgery when someone has an enlarged pituitary gland. We work with endocrine surgery or ENT to take out parathyroid glands or thyroid glands if needed. And, we work with OBGYN when someone wants to get pregnant and they have a history of PCOS or another form of hypogonadism. We work a lot with rheumatology, because patient, and hemonc as well, like hematology oncology, because a lot of those folks are on steroids that exacerbate their blood sugars, for example. They also, for hematology, we have a lot of patients with cancer that are being treated with new medications that actually cause a lot of endocrinopathy. So it might fix the cancer, but it ends up causing a thyroid disease. Or so there's so much overlap and a lot of connections that we form with other specialties throughout our clinic day. And so, it's interesting, sort of, you still touch on all those specialties, even though you're still sort of focused in on your own area. And I think that's actually one of the most fun parts of medicine, because you can't actually forget everything you learned in medical school or even residency. It's easy to, because you get very, very focused on your own area, but it's really, really important to kind of keep things in mind, and you need to know kind of when to refer who to, like what kind of doctor or what kind of specialty. So, that's kind of my focus. And so my clinic day, or just my work day in general, it's a bit of a combination of inpatient endocrine consults and outpatient clinic. And so for consults, if there is a patient admitted in the hospital that has an endocrine issue, like high blood sugars or thyroid disorder, and they came in with thyroid storm or something endocrine related, the primary services will call our team to come in and put in an opinion on what to do for the patient. So that might mean insulin management, that might mean changing their thyroid medication dosing, their dosing for their hydrocortisone for their adrenal insufficiency, and the list goes on, of course. And so we spend part of our time doing that, rounding in the hospital and seeing patients that are admitted to the hospital. And then the majority of my time is spent seeing patients in clinic. And that's kind of most of my day. And so, one after the next, we see patients in clinic. And, unfortunately, I'm booked out until March. And so there's not enough endocrinologists right now. And so there's a very, very high demand for people to go into the specialty. And, unfortunately, it's not the highest paid specialty. It's actually one of the lower paid specialties. But I don't think I would really enjoy any other specialty. I really love what I do, and I love the topics that I think about, and what I treat patients, how I treat patients. And so, I don't ever go after money in a certain specialty, because if you don't love it, you don't love the routine, the money is not going to mean anything. And so, I've never met an uncomfortable or poor doctor, right? So no matter what you do, you're going to be compensated well for your time, but do not focus on what your income is going to be in terms of choosing a specialty. Like, really think hard about what specialty you really want to do. And so, like that decision you make in medical school, whether you want to do procedures versus no procedures. For me, honestly, I realized I don't ever want to see the number 3:30 on my alarm clock to get up and go around in the hospital and go to surgery and all of that. That just wasn't me. And honestly, I really like my clinic time with patients. I like taking the time to talk to people, and others like to be doing procedures during the day. So everybody's sort of wired differently. That just ended up being kind of like my vibe, and I really, really enjoy getting to know people and talking about food all day. So that's in terms of my passion within endocrinology. Diabetes and weight management have really kind of become something I feel like I could do all day. And, with diabetes, people come in with, good blood sugars or pre-diabetes up to, extremely uncontrolled blood sugars and all the complications like being on dialysis or needing kidney transplants and that sort of thing. And so we see kind of the full spectrum. And, the interesting thing is that there's so much drug development within the diabetes space that, it's really interesting to kind of see what advancements we've had in medical management of diabetes. So it's not just insulin, and there's so much that you can do to be able to get someone's blood sugars under control. Now, this is for type 2 diabetes, type 1 diabetes, people need insulin basically to survive. So they're two completely different diseases, even though they're named the same, but it's a little bit of, everyone kind of has their style. Everyone has their little bit of flair with how they treat various conditions. And I honestly get really excited when I see someone who's brought their blood sugars from, really high levels down to normal levels because they, made changes in their lifestyle, or we changed certain medications or that sort of thing. And so, the number one before any kind of medication is introduced, especially for type 2 diabetes, is lifestyle. So, that's where my interest in food and weight management comes in, because, once you tweak what you're eating, i.e. like a lower carb diet, higher fiber, higher protein intake, and up your exercise, all of a sudden your insulin needs go down. And so to be able to talk through, strategies as to how to do that, what I've found is that a lot of people, unfortunately, and this kind of goes back to my earlier research with diabetes literacy or health literacy in general, but people don't understand how to read nutrition labels. People don't know what a tablespoon is. They don't know what a teaspoon is. They don't understand what a milligram is. Or a gram of carb versus 15 grams of carbs versus 60 grams of carbs. And so, we're there to, as educators, we're there as their doctors, and being able to talk through, how to structure someone's lifestyle or what they're eating throughout the day, or how they make those decisions, I think is super fun because one, I'm a huge foodie. I absolutely love to cook. And I absolutely love chit-chatting about how someone can make changes in what they eat and how they eat, without having to necessarily eat boiled broccoli or steamed broccoli all day long. So, my philosophy with all of this is that healthy food does not have to taste bland. It doesn't have to be boring, and it can actually be fun. And I think, it's very much a mindset in terms of it, and that goes for both diabetes and weight management, right? So you kind of have to be there in like the right headspace to be able to embrace that, because I can't, if you're not willing to do it, it's very, very hard to make someone do something. So, part of the job that is to really sort of help empower patients and give them the resources to be able to make those kinds of decisions to better their health. And so, I kind of call my clinic space like a non-judgment zone because, unfortunately, if you've been 400 pounds for however many years, you don't feel that good about yourself. And there's a lot of issues with mental illness and depression, and, it just becomes a vicious cycle. So, I'm kind of there to help break that cycle and, help kind of get people on a certain path. And sometimes it works and sometimes it doesn't. And that's just unfortunately or fortunately the nature of medicine, right? So, there's no perfect science, there's no perfect dosing. You kind of have to individualize your therapies and your approach to everybody. I wanted to quickly show you just in terms of what I see every day. I just wanted to share the screen. So, just to get into kind of how I look at blood sugars and how I manage diabetes, I just wanted to quickly show you how we monitor. And so I'm sure there's somebody in the crowd here tonight that has a family member with diabetes, or you have diabetes yourself, and you've used a continuous glucose monitor. And so technology has gotten really, really great where, finger pricking is no longer a necessity to manage your blood sugars. And so we've got continuous glucose monitors, and, especially with the pandemic, we can grab this data remotely. We can manage our patients via telemedicine, and based on someone's blood sugar trends, I can pretty much tell you pretty close what their A1C or blood sugar control would be. And so it's actually been a huge blessing. Like this was around obviously before the pandemic as well, but it's proven to be extra valuable through this, because you don't have to come into clinic or drive 3 hours to see me, because I can pull up your blood sugar data, through the portal. I can figure out what your dosing can be, tell you over a video visit, and we're good to go. And so that's not the only purpose of it, but the nice thing is your family members can follow along what your blood sugars are. If you're at risk for highs or lows, they get alerted. So the safety measures here are wonderful. And I think the other thing is that with these continuous glucose monitors, when you see your blood sugar rise due to eating various foods, like if your blood sugar goes this high because you ate a pizza versus if you had like a salmon and vegetables and it stays flat, it sort of coaches patients that, okay, well, when I ate that like protein and veggie dish, my blood sugar didn't spike as bad. And so my blood sugars are better and I should do this more, or I should really cut back on how much pizza I eat, because when I ate those 4 slices, my blood sugar shot through the roof. So if I did 1 or 2 slices and a salad, my blood sugar won't spike as bad. So, so it's interesting to kind of, I think it's been a really great behavioral tool, but then also it helps us help patients dose their medications better. So this is just a couple slides. I just wanted to show you what a CGM download looks like. So let me just pull that up. Oops. Okay, so this is just the report that we usually print out. And there's 2 different types of CGMs that we often use in our practice. One is a Libre and one is a Dexcom. And so this is a patient who has an average blood sugar of 105. It's really, really good. She's a patient who actually was on insulin a few months ago, and she's been able to actually wean herself off. Over here on the right, we look at time and range. So time and range is really important, because that tells us, well, how much of the time are these folks in a good blood sugar pattern? Because the thing is, the average could be good if you had like if you had blood sugars in the 300s and you had a blood sugar in the 50s, that would be still really good average. But you want to kind of see in the target range between 70 and 180, how much time are they actually spending in that? And you know, for this patient, for example, 98% of the time she's in target range. So this is just a summary of her blood sugars, for example. So as you can see, like these are pretty flat lines, like her blood sugar control is excellent. And this is just, you know, day by day, just recently, you know, she maybe spikes to like 130s after, you know, lunchtime or so, but overall, like she is as steady as can be. And so, you know, this is a patient, again, off of all insulin. She hasn't needed insulin now in a few weeks, and she's obviously maintaining really, really good control of her blood sugars. And so this is another example. So this is from a Dexcom download for another patient. Now this patient was having a few more glycemic excursions. So excursion means highs and lows. And so if you look at, you know, this Wednesday, October 21st, he ate a meal, went up real high, gave himself too much insulin. So this is a type 1 patient, whereas the other patient was a type 2. He gave himself too much insulin for his dinner on Wednesday and then dropped too much. So so the nice thing is with Dexcom, it alerts you or beeps like when you're about to go low, so that the patient can preemptively correct it versus crashing to like a much lower blood sugar. So this is, again, this patient, he said that he was actually having kind of a rough week, was off of his routine, and it totally messed with his blood sugars. And so usually this patient is actually quite close to being very, very straight and stable throughout. And so this was just different for him. But you can see every time he eats like a late night meal or a snack, he spikes real in the middle of the night every night. And so then he probably gives himself a little bit of insulin, you know, in the middle of the night to correct it. And then he drops kind of low. And so that's like the Friday, October 16th measure. Same with the Wednesday, October 14th. He went up too high, gave himself insulin. That didn't drop him too low. The red line is the hypoglycemic line. But you're seeing that like every time he eats a late night meal, he drops significantly. And so our goal is to, you know, manage blood sugars in a type 1 patient to make sure you're as steady as possible, because you want to mimic the way pancreas produces insulin. And so that's just an example of sort of how I manage, you know, diabetes, especially in a patient with type 1, but more and more of our type 2 patients are using continuous glucose monitors now as well. And it's actually been extremely valuable in terms of, you know, again, one, behaviorally for them, but then two, I am very easily able to change their medications. I guess if you guys have any questions, I'm happy to answer.
Yes, so there have been a lot of questions in the chat. And then if you guys have more questions, go ahead and ask them. Those can also count for attendance. So feel free to just ask whatever you want. So there has been a lot of questions. If you could speak more to your culinary medicine certification and what exactly that entails, how you got into it, what you hope to do with it.
Yeah. So this was, you know, I just sort of by the by kind of found that this certification existed. So it's actually been around for a couple years. The program that I'm doing is actually through Tulane University, but there are some other programs, I think, through the Culinary Institute of America out of Napa. And then I believe Harvard has a course as well. And so, you know, basically like the motto of the program that I'm doing is health meets food. And so basically, you know, my goal, especially as an endocrinologist, is to, again, be able to give patients options and help them learn about how food affects their health. And so effectively, like the entire premise of this licensure is how food is medicine, right? Food is medicine. Because, you know, first of all, the way that typically, you know, we recommend people eat is high vegetables, so high fiber, high whole grains, protein intake, you know, basically like a Mediterranean style diet. However, in the US, most people are eating more processed foods, more sugar, just a lot of junk, unfortunately. And it's led to 2/3 of our population being overweight or obese. And so the way that I'm using this licensure is to really help guide my practice in terms of how I can counsel patients to one, empower them to not necessarily even cook, but to make those right choices. And sure, like you could get, you could become a dietitian, you could become, there's lots of ways of doing this, but I love the cooking part of it, right? And so it doesn't, basically my premise here is that good food does not have to be bland or boring. And I think, one thing a lot of people have embraced during this pandemic is home cooking, because we couldn't go out so much. And it's amazing to see sort of how patients have embraced it. Some have had a much harder time and have had, have stress eaten and they've gained weight, or a lot of takeout, that kind of stuff. Others have done great, like they're cooking at home. They've really sort of embraced what healthy food really is, or like minimally processed foods versus eating out. And so that's just like a kind of an overview, and everybody uses it differently. In this licensure, people, primary care physicians are doing it, pediatricians are doing it, psychologists. So you could basically use this in any specialty. It's quite generalizable. But for my purposes, I've really decided to focus on lower carb, weight-friendly foods.
Great, thank you so much. So there was a question asking if you work with children, or if you don't, do other endocrinologists work with children?
Yeah, so I'm an adult endocrinologist. So I did a residency in internal medicine, which is adult. So if you want to work with children, you would go into pediatrics. There is an option to do med peds, so medicine and pediatrics, where you treat both adults and children. And so my fellowship actually was a combined pediatric and adult fellowship. So I did have some experience with children when I was in training, but my primary patient population is above 18. Once in a while, I'll see patients like 15, 16. But there is a separate pediatric endocrine fellowship after you do a pediatric residency. So they are separate. And the reason why that's so important is because some of the disease processes pediatric endocrinologists see are totally different than what we would see. Like hypogonadism, for example, or growth restriction, and that sort of thing. And so there's a lot of stuff that not necessarily adult endo sees versus peds. So it's totally, not totally different specialties, but different training.
Kind of bouncing off of that on patient populations, someone asked if you work with transgender patients and when they're transitioning with their like hormone levels and things like that.
Yeah, so I do have some transgender patients, and so some of them it's at the start of the transition process. Some of them it's just continuity of care and continuing their hormones. This is more of a niche specialty, like within endocrinology. And there's some certain centers like in the US that are much more focused on transgender treatment versus general endocrine, but we're all trained to do transgender therapy. And I'm very comfortable doing that. The nice thing is actually in Chicago at Rush University, they have an entire brand new transgender care center. And so for those looking for, a comprehensive care with like psychologists and urologists and, surgeons and everything, that's in Chicago, that's actually the newer and like a great resource for us to have if we need more further specialized care for them.
How do you deal with patients who are resistant to your advice, but they want to change, they want to lose weight, but they're just not following what you're saying?
Yeah, sometimes, I gotta say, sometimes I'll see patients for the first time for weight management, and I may never see them again because I might scare them because it seems like a lot of work. And then others, they'll come in and like slowly start and get motivated, and it's amazing to see their journeys. And so one patient, I'd love to give you this example. I've been treating him for about 1.5 years now. So he's in his 50s, and he was referred to me because other people thought that he had Cushing's disease. So Cushing's disease is an excess of cortisol production, and it creates a very characteristic physical appearance. So what you get is a very, very large abdomen, skinny arms and legs, a round face, lots of bruising, and then purple pink stretch marks on the belly. And so so I did the whole workup for Cushings and all of that, like a full, because there are endocrine causes to weight gain. There are hormonal causes that can cause weight gain. And so one of my duties is to basically figure out, is this kind of run of the mill weight gain, or is this hormone related? And how do I, you have to treat kind of the central problem first before attacking like the actual weight gain, for example. Anyway, so I worked him up. He didn't have an endocrine cause for his weight gain. And so we started, talking about, okay, well, let's put you on diabetes medications, get your blood sugars under control. Let's transition your diet. So he was like close to 400 pounds, maybe high 300s from what I remember. And, diet, again, high in processed foods, carbs, the whole deal, very, very difficult to get around. So his stomach was, so enlarged that it went down to his knees. And so it was to the point where he was really disabled. Like the poor guy like had terrible back and hip pain, a lot of joint pain, because obviously like all that weight is weighing down on your joints. Couldn't really get around. Like his physical activity was extremely limited because of, like this huge pannus that he had, unfortunately. So what we did, we started him on medication, got his blood sugars down. He started to make changes very slowly. And I remember it took months and months and months for him to start embracing more vegetables, for example, and start cutting down his carbs. But slowly but surely, he started to see the difference, right? Because he started to lose some of the weight by just changing his diet. It was frustrating because he wasn't losing it as fast as he could. And he actually would have been a good candidate for bariatric surgery. However, if I sent him for weight loss surgery, he would still have this huge pannus weighing him down. So what we did, we fought for like 8 months with insurance to get him approved for a paniculectomy. And so, but that's kind of taking off that large piece of skin that's hanging over the groin. And so he finally underwent plastic surgery like 2 months ago. He has a new life. Like, it's amazing. He has, just by taking that pannus off, he lost 35 pounds. He was like, I'm doing stuff that I haven't done since I was like a teenager. He's mowing the lawn. He is cooking at home with his wife. His relationship and with his family is much better because he's just motivated. He's moving around more. It's just incredible. So in total, this guy has lost about 60 pounds in the last year. He's a rock star. And I think that's like one of my favorite things, is having someone start kind of not sure what they're going to do. Are they going to follow through? Are they going to, see me again, that kind of thing. And he's been super consistent. He's coming, every couple months to see me. And not that I'm tooting my own horn, but he truly, in the hospital, when I went to see him after his surgery, he's like, you changed my life. And this is why we do what we do, right? And this isn't all patients. Again, like some patients, they come in and they're not ready for the work it takes to lose weight. And unfortunately, I think some of them are come in like wanting kind of a miracle drug for weight loss, and we just don't have those. And the thing is, like, I always kind of quote or name these drugs, like I call it the cherry on top to all your efforts. So without that lifestyle change, without, making those dietary changes or increasing activity, no amount of drugs I give you is going to help. So it's very much like a mindset. And if you're ready for it, great. And some patients have admitted, like, if I'd come in 5 years ago, I wouldn't have done it. So it's very much like where you're at from headspace standpoint. And if you want to go through with it, awesome. I'm there for you. And if you don't, then fine. I'm here anyway. Whenever you want to come back, I'm available.
That's a really great story. People in the chat were saying that it's amazing. So there's another question asking if you've noticed certain hormonal patterns in certain populations, such as certain races, certain genders, certain socioeconomic status, things like that.
Not necessarily hormonal patterns. It's, physiology is physiology, but, certain diseases we see disparities with. And so obviously, like in our Black population, we see much worse diabetes and high blood pressure. And this kind of goes back to, the disparities that I worked with, long ago in college. it's very much, it comes down to access to care. You know, there's so many barriers to care, food insecurity in some of these communities. Like, I mean, I did residency and fellowship in the South Side of Chicago, at University of Chicago, and some of these people had no grocery store nearby, you know, and so, you know, all that's available to them is processed food. And so no wonder they've gained weight. And so it's not necessarily hormonal patterns in various races, but you're going to see, depending on what the disease process is, some races might be affected much worse than others.
Thank you. There were a couple of questions about how you have been impacted by COVID. So have you seen an increase of patients wanting weight loss aid? Have you done telemedicine? How exactly has your practice changed?
Yeah, actually it changed a lot. I think we're one of the few specialties that was able to go 100% remote from like March to July. And so, you know, the continuous glucose monitoring was so valuable during that time because I was able to just quickly download it. I had them on, you know, a video chat. You know, I had their chart up, and so we were good to go, right? And so we're a lab-based specialty. So if I have your labs in front of me, or I order labs and you get them at any time, as long as I get them and I can interpret them, we're good to go. So it actually, it's been a bit eye-opening, at least for our specialty. I don't know very many other specialties that can go 100% remote, but I think, you know, based on sort of what we've done through this pandemic, telemedicine is here to stay. And you know, obviously a lot of this is dictated by insurance companies, which that's like a whole other discussion with how the system is structured. But I think, you know, after all this is said and done, it would be just foolish to go back to all in person, because we're able to do so much virtually. And, you know, and the other thing is, some people drive 3 hours to see me. Some people just had surgery last week. Some people are wheelchair bound. Like, if I can see them on video, treat their diabetes and send them on their way, like, why not? I helped somebody without inconveniencing them. So in that sense, it's actually been a very interesting transition, like during COVID. Now we're back in person. We're seeing about 50-50, or about, like, you know, 60-40 telemed versus in person. But right now we're sort of leaving it up to the patient. If they want to come in, they can come in. But, you know, I still fully wear my PPE when I see patients, because the way that I function anyway, and this isn't everybody, this is just me. I just sort of, I have to work as if everybody around me has COVID. And otherwise, I mean, I've got a family to come home to and all of that. Like, we've got to be just as careful. So, you know, it's been different. I mean, I don't enjoy wearing an N95 all day. My face aches every single day. And I'm definitely not going to miss this once it's over. So I don't think anyone will.
Someone asked, so since you said that virtual can be just as good as in person, is it not as important to do full physical exams in your specialty?
It depends, right? So I would say the thyroid exam is actually really important. So one, obviously feeling the thyroid, but for example, when someone is hyperthyroid, they may have an elevated heart rate, they may have tremors, they might have, you know, increased reflexes. So it does truly depend on the condition. But it's amazing what you can pick up by just seeing somebody on video. So I can tell based on what their eyes look like, what their neck looks like, even via video, whether or not they may have something going on. Now, this is not a perfect science, obviously, because someone could have a thyroid nodule that they may not feel, but I do on physical exam. So this isn't obviously perfect, but in the purposes of the pandemic and the lockdown, this it was very, very valuable to have telemedicine.
There were a lot of people wondering what your most memorable or interesting case has been.
In endocrinology, or just in general?
Probably just in general. I'm sure they wouldn't.
You know, there have been so many throughout. Like, some of them are really sad and some of them are super happy. Like my patient with the paniculectomy, he's one of my super like success stories. I just had a woman a couple days ago. She initially, you know, the thyroid gets blamed for a lot of problems, right? And I feel like the thyroid gets way too much credit, because there's not, if, you know, someone's tired or feeling kind of low, oh, it must be the thyroid. It doesn't work like that. So anyway, this woman came in last year with just feeling tired and just kind of run down and everything. And thyroid was fine, of course. And so we started talking about weight management. She's now down 75 pounds. She feels amazing. She's like, I'm back at my wedding weight. You know, and I feel like we really made an impact on her well-being and overall her quality of life. And without someone pointing out like, okay, it's not your thyroid. I think you really need to change the way that you're eating and drinking and like exercising. And I have her on medication to help with weight loss as well. You know, I think it's really changed people's lives. And the other thing is that I think it's really important to make sure that weight is not stigmatized, at least in our environment. Weight is definitely stigmatized in society. And that's why I think people do feel so judged by society. But nowadays we treat weight like we treat a chronic illness, like high blood pressure or high cholesterol. And so I feel like some of the time, like patients have to sort of break that stigma for patients as well. Like what, like I can't be on a weight loss medication. How can I do that? But why? This is a chronic illness that you have, and it's affecting a lot of different processes. And so that's kind of the mentality that I function by just in clinic. But other cases, my gosh, like I remember, and I'll never forget this case, my intern year, and this is like, you know, 2-3 months into residency, there was a vet from Afghanistan. He was only 21. He had a cough while he was abroad, and ended up finding some lung lesions, and he had an extremely aggressive cancer. And you know, I'm never going to forget that. He had a fiance at the time, and within a week or two of him coming into the hospital for more shortness of breath, he was gone. And it's those kinds of things stick with you, right? Like, and I think that's a good thing, because you don't want to forget like why you did this in the first place, and you don't want to forget that humanity. But we cry with our patients. Patients' cases make us sad. Endocrine overall is a happier field, I think, which is why I didn't do something like hematology oncology. I just don't think personally I could handle it. But you know, the people who do that are super strong, and they're really good doctors. And you have to sort of compartmentalize a little bit, right? Like otherwise you can't carry the weight of the world on you at all times. And so you have to be able to compartmentalize a little bit and find that balance. Because yeah, like certain stories and certain cases, you do bring them home and you do think about them, and they do make you sad. And yeah, there's just so many of these cases, too many to name right now, but that I don't think I'll ever forget.
Someone asked what kind of procedures, if any, you do as an endocrinologist.
Yeah, so currently I don't do procedures, but the only real procedure that endocrinologists typically do are thyroid biopsies. And so I was trained to do them in clinic during my fellowship. And then I worked at Rush Hospital before I started at Northwestern, but we were doing them in clinic then. And so basically it's ultrasound guided, and you would do the biopsy, just needle biopsy in clinic itself. But again, we're mostly a lab-based specialty, and we love numbers. We love analyzing a lot of labs. And so, but yeah, there's not too much procedures, but we do look at imaging and look at labs and correlate based on that.
Someone asked where you would draw the line between your scope of practice with the culinary medicine license and that of a registered dietitian nutritionist, and how closely you work with them on a day-to-day basis.
So I work with my dietitians every single day. And so it's a little bit different because their entire management is like dietary, right? I'm bringing in physiology and medication management and like a side of like the culinary part. And so I think, you know, as a physician, I do have a different perspective on just the way that we construct instruct patients on how to make those lifestyle changes and that sort of thing. We partner together all the time. And so, you know, for example, like my dietitian and I, we've been doing lectures in the community together, like we tag team. And so I talk about the physiology behind, for example, weight loss. And she talks about cravings and how to help reduce cravings and what kinds of foods to introduce to, like, you know, things like that. So I think we complement each other more than overlap, actually. And if you do it right, I think you can become like a pretty effective team. I don't think I could function without my dietitian.
So this is kind of going off when you were talking about giving lectures. Does endocrinology incorporate diabetes prevention into practice? And if not, do you wish that prevention was more prevalent in medicine?
So definitely, because we wouldn't be where we are now, like with, you know, almost a third plus patients with diabetes in this country, 2/3 with obesity. So 100%, like prevention is key here. And so again, like endocrinologists, like there's only a few thousand of us around the country, right? And there's like 300 million people in this country. And so, you know, by the time someone gets to us after being booked out for months and all of that, you know, they've gone through primary care and everything. And so obviously primary care, I think their primary focus with diabetes and weight definitely is all prevention. Some of the time I do see patients with pre-diabetes, for example, and so preventing them from developing diabetes is huge for them, right? But the same thing with weight management. So, you know, if patients even lose 5% of their body fat, all of a sudden, all their numbers like blood pressure, A1C, like their diabetes management, their cholesterol, all of that stuff gets better. A 10% weight loss improves your sleep apnea by 50%, right? So little bit can go a long way, but it can have such an impact on someone's overall health. And at this point, obesity is sort of known to affect every single organ, every single, you know, part of your body. And so prevention is key here. And so, you know, unfortunately, some of the time as specialists, we see patients much later on, but wherever I can kind of get my claws into someone where I can practice prevention, I'm all for it.
Someone asked, so, you know, we hear like it's all about the food you eat for weight loss, or some people say it's all about working out. So how important do you think physical activity, going to the gym is for weight loss?
It's not all what you eat and exercise. If it was that easy, you know, we would tell everybody to do that. So much of weight is hormonally mediated, and the way that various hormones interact with certain parts of your brain. Some are genetic, some are, you know, so there's so many causes for why someone might have issues with being overweight. So I don't think it's as easy as just putting it into those boxes like exercise and, you know, diet and like you're on your way. That's a big part of it once we start to treat it. But you know, they're both super important. So exercise is not necessarily used for weight loss, but it's actually used for weight maintenance. The other is that the more muscle you build, the metabolism does get better, blood sugars get better. I think it's been a great way actually for me to be able to reduce insulin needs for patients, for example, because they're working off their carbs by exercising and unfortunately insulin causes weight gain. And so, that does help to reverse the process a little bit, but you could exercise like, you know, 2 hours a day and still eat like super processed high carb foods and you wouldn't lose a lick of weight. So it really goes hand in hand. I think one without the other, like you're not going to see as much of an impact.
So going off of diets, what are your thoughts and recommendations on plant-based diets, vegan diets, or all these kind of fads that are coming in?
Yeah, that's exactly what they are. They're all fads, right? So, and the reason why they're fads is because you could try Whole30 or keto or whatever for however many weeks or months, but eventually people burn out. And that's kind of the usual trend for a lot of these diets. And the problem is once let's say you lose, you know, 25 pounds on keto the first 2 months of doing it, like that's great, but how are you planning on sustaining that like long term, right? So when I talk to patients, I often talk to them about, well, okay, great, like you can do keto for a month, but what's your 5-year plan? What's your 10-year plan? And that's where lifestyle comes in, because if you sort of start embracing a lifestyle more consistent with like a balance, and you know, this is like as like corny as it gets, but everything in moderation, right? But it's so true. And so if people are sort of balancing it out, they're less likely to burn out. And so there hasn't ever really been a diet that has said, okay, this is the diet, like this is the guaranteed thing that's going to help you lose weight. Studies have found over and over again, the diet that works the best is the one that you can sustain. And so in my experience, it's been the folks that end up kind of balancing it out with like a higher portion of veggies, like a medium portion of protein and a smaller portion of carbs. they tend to do the best because you're not telling them to omit anything, right? When you tell someone you can't eat something, they want it more and more. And so what I tell them, okay, well, just cut back on those portions, especially the carb portions, up your veggies and see how you feel. If you're still hungry, eat more veggies. But like protein as well can cause weight gain. So it's very much a balance thing. People will cheat, that 100%, this is just life, right? So those fad diets are not going to work long term. And, you know, people come in like, oh, I'm going to do this. And then like, oh, okay, great. I'll see you in 3 months and we'll see how you're doing. But like, you know, veganism, plant-based, definitely. I mean, there's so many health benefits to it. But the thing is, like, if you don't want to go fully plant-based, that's okay too, right? Like, as long as you add more vegetables in your diet, veggies are always good for you. So a little bit more is never a bad thing. But I think the point is to really try to cut back on the processed foods and refined carbs.
Another question was, you mentioned earlier in your talk about PCOS. So how closely do you deal with that? Or is that more of a gynecology specialty?
There's a bit of overlap. We get a lot of referrals for PCOS, so polycystic ovarian syndrome. And so it's actually a metabolic disease, right? So it's a disease of insulin resistance, actually. And so a lot of these visits actually end up becoming weight management, you know, blood sugar management type of visits, because by doing that, your insulin sensitivity improves, and that often ends up restoring cycles in people who've had, you know, irregular cycles and things like that have led to that PCOS diagnosis. There's other things, like people will have sort of androgenic features like increased hair growth or increased acne and things like that. And so we often end up having to treat with a birth control pill and then mitigating, like, how do we help lose weight to improve insulin sensitivity.
Kind of bouncing off of consulting with other specialties, how often, do you work with people that are in the ICU? And then what is really the difference between like a hospitalist and endocrinologist?
Yeah, so we work with the ICU team all the time. And the reason why is that a lot of our patients come in diabetic ketoacidosis. And so those are folks that have severe metabolic derangement, extremely high blood sugars, and they typically need to be in the ICU for a day or two being on an insulin drip to correct those metabolic derangements. Now, you know, the ICU, like the intensivists and the nurses are there at all times. And so those are our intensivists. And then a hospitalist is someone who has trained in internal medicine, and they may have done another fellowship in medicine, but they basically manage patients who are admitted in the hospital. In clinic, like that's outpatient, so those are not hospitalists. Hospitalists are those who just work in the hospital, managing patients that are admitted in the hospital.
So another question that someone had was, what is the minority representation like in the general field of endocrinology? Minority
representation. So I think actually it's gotten much more diverse, and there are more women in endocrinology than men, which is awesome. But minority representation, I think it's actually much, much better. I don't know exact numbers, so I apologize for that. But there's definitely more and more minorities, you know, pursuing endocrinology, which is great because I think that helps them relate to their patients, and it's created like a great diversity in the field.
You mentioned at the beginning that you didn't really like waking up at 3:30, doing the surgical rounds. And so how do you, as an endocrinologist, what is your work-life balance like? How do you manage having a family, seeing patients, and then just having
not easy all the time. I will say that this specialty has made it a little bit easier to have a little bit more of that work-life balance because I have my set hours in clinic. You know, it's a kind of like an 8 to 5 schedule, and that's when I'm working. And after 5 o'clock, I'm mom, right? And so I have a 3-year-old, and my husband is a cardiologist, and our entire life is a constant juggle between my schedule and my husband's schedule, and making sure that, you know, my son is taken care of, you know, and so we have hired help. Like, we can't function without that, right? And we need those resources to be able to function as a family. And so, you know, I work full time. I don't plan on switching to part-time anytime soon anyway. And, you know, we make it work, but it's very much like we're on top of each other's schedules. We plan ahead. We ask for help, a lot of help. You know, my family, our nanny, like everybody, we couldn't function without all of that help. And so don't be afraid to ask for help, you know, otherwise you can't, it's very, very hard to do everything you want to do. And so it's a little bit of give and take, but I don't think I would change anything, you know, and some days are harder than others. Honestly, it's being a doctor mom is an interesting adventure to say the least.
Someone asked, you know, we've been talking a lot about obesity and patients who are overweight, but do you ever deal with patients who need to gain weight, and how do you go about that?
Not so much. Oftentimes those patients are seen by GI nutrition because they end up needing like parenteral, which means IV nutrition or tube feeds and like that sort of thing. So oftentimes like underweight or malnourishment, I don't see as much as gastroenterology, but in the few times, you know, for example, a cancer patient who's losing weight and that sort of thing, we need to make sure that we counsel them about how many calories to try to take in and prevent further weight loss. And so, you know, certain medications for diabetes these days, they're great at, you know, helping people lose weight, which is wonderful, but you have to make sure that the patient is appropriate for that. So you don't want to give a medication like that to someone who is in the middle of chemotherapy and having ups and downs in their appetite and potentially will lose more weight. And so you've got to tailor your therapy according to the patient.
So this is going to go ahead and be our last question for tonight. What advice do you leave us pre-med students with, you know, an undergrad applying for med school, especially now with COVID?
Yeah, you know, this is like a really tough time for you guys. And I'm so sorry that this ended up being the year it was. But what I've actually seen in a lot of people is how resilient we can be as a society. You know, and so don't give up on your goals with this because we need you now more than ever. You know, and the other thing is like, it also sort of solidifies what a privilege it truly is to be able to take care of people and to be able to use that expertise to like help save someone's life or change someone's life or quality of life. And so, you know, through the pandemic, in terms of, you know, pre-med, I think just keep studying as hard as you can because obviously grades matter. Expose yourself to various opportunities. Now, I don't know how easy that is, you know, in the middle of all of this, but make sure that you're looking out for research opportunities or the ability to like work with patients at some point, and make sure that this is really what you want to do as well. I don't want to make it sound rosy all the time. It's not always easy. There's a high rate of burnout with physicians. I work super hard. I'm booked out for months and months. I have, you know, routinely above 150 results to get back to. Like there are days where you're just like, oh my gosh, like you're just feeling like one of those, you know, a hamster in one of those wheels. But you got to take a step back at that point and realize like why you're doing this in the first place and why you really love it. And, you know, I think for pre-med, I would say, you know, get those experiences so that you know what you're getting into, but work hard. I mean, and definitely don't give up because I know like MCATs and everything like that is tough, but I think you guys can do it. We need doctors. Like there's such a shortage of doctors and good doctors. And so please, yeah, don't give up on that dream.
Thank you so much. I don't know if you can read the chat, but was very inspired and really liked your talk. They said that endocrinology is very interesting and they learned a lot from you. They said that you were a very easy speaker to follow. You spoke very well. So
feel free to reach out to me if you want to email or even like via Instagram. Feel free to reach out for any questions or anything, you know, that I might have addressed or something that you had a question about that wasn't answered.
Do you want to go ahead and tell them your Instagram handle?
Oh, sure.
Or I can.
Disha Narang, MD, DISHA NARANG, MD. So feel free.
Perfect. I just put
perfect. Yeah. Feel free to give me a follow. If you need to ask any questions, please feel free to reach out. I'm more than happy to address them.
Thank you so much. This was awesome. Have a great night.
You too. Take care. Nice to meet you.
Yes, you too. Bye. Thank you so much. If anyone here has any questions for me, please feel free to ask in the chat or unmute yourselves and ask. I'll stick around for a little bit.